Dr. Cohen. How are you
Hey,
today?
Mara, how's it going?
I'm doing great. Thank you so much for joining us. This is going to be an awesome session. We're going to discuss all things laser resurfacing on the True Skin Experts live series through the ASDS. So welcome.
Thank you. It's great to be with you.
Great. So before we get started, I just would like to introduce everyone to the series. This is the True Skin Experts live series put on by the ASDS. We try to hold sessions at least once a month, led and discussions amongst board certified dermatologists. We discuss all things beauty, health, skincare, injectables, and it's really from experts who've had 13 plus years in training and schooling, and then 13 and beyond plus years in real life experience. So these are really special discussions that we have, and we're excited for everyone to join. So tonight we're going to be talking all about laser resurfacing. And before we start, I would just love for Dr. Cohen to go ahead and introduce yourself.
I'm a board certified dermatologist. I did a fellowship in Mohs surgery with the Mohs College Fellowship and aesthetic dermatology. So I learned injectables during my year fellowship with Alistair and Jean Carruthers, and lasers with Jason Rivers and Harvey Louie and all the experts up in Vancouver.
That's super impressive. And Dr. Cohen, how many years of training would you say, like to sum it up just for our viewers, like how many years of training was that to be able to do what you do?
Well, 4 years of college, 4 years of med school, a general surgery internship, 3 years of dermatology, and then a fellowship for a year plus. So a long time, but thank you for emphasizing it's been 13 plus years. Explain gray hair here. Hi, Mara. That's a good thing we know each other well and you can make fun.
Well, wanted to start it off light, right? And I'll just do a quick intro. I'm Dr. Mara Weinstein. I'm a board certified dermatologist and assistant professor at the University of Rochester. I also did a similar training to Dr. Cohen, not quite as many years, but I did a fellowship at Skincare Physicians in Boston, post-residency in dermatology and aesthetics. And, both Dr. Cohen and I have done a lot of research in lasers. His resume is probably like 30 pages longer than mine, but we are so excited to be able to kind of pick his brain tonight and get some questions rolling. But again, before we start, I just have one question for you, Dr. Cohen. If you were not a dermatologist, what would you be? What would be your career?
Honestly, I would have been a hockey player, but I wasn't good enough to make the NHL, and I'm too old and fat to do it now. So this is what I'm stuck with.
And tell us a little bit about your hat. Is that a favorite team you have?
Yes. So I grew up in metropolitan Detroit, and I was a diehard Red Wings fan. All my cousins and family live in Canada, and on both sides. And I've been a huge hockey fan. In fact, I'm going to be in Canada over the next couple of weekends, so I'll have a lot of hockey trivia going on. But when we moved to Colorado, that was the biggest rivalry in NHL sport, and in all of NHL was the Red Wings and the Avalanche. So I've become an Avalanche fan and a very significant Avalanche fan.
Awesome. Well, in Rochester, we have a minor league baseball team, the Red Wings, as well. And so we're big Red Wings fans, but in a more like local, low level situation here. But it's very cool to see that. So thank you for sharing.
Sure.
So let's get started. Okay, so the topic of the night is laser resurfacing, how to get your skin glowing. And we as dermatologists know that entering into the fall is, our laser season. So can you tell us, when patients ask for laser resurfacing, what does that mean? How do you explain it to them?
So laser resurfacing is really an opportunity for us dermatologists and aesthetic physicians to take the skin and understand that the sun and age-related changes happen over time. And with cumulative sun exposure, we get rough skin, we get pigmentation in the skin, we get etched lines and wrinkles, and we can improve the appearance of this using different types of laser devices. Many and most of these devices have been pioneered by dermatologists. Richard Fitzpatrick really is the principal one who did heavy full field resurfacing, and then obviously Rox Anderson and Dieter Manstein did fractional resurfacing and putting little micro columns into the skin. But what all that does is repairs, regenerates, restores a healthy, youthful appearance to the skin.
Yes, agreed. And this is such an important time, especially in upstate New York or in like the East Coast, where patients are asking for lasers because they're noticing all that damage done from, you know, the summer and spring weather, and they're noticing, like you said, more fine lines, wrinkling, brown discoloration. So if a patient is laser naive and they heard that, you know, Dr. Cohen does lasers, like go talk to him. He can get your glow back. What would you start with? How would you counsel them if they've never had a laser before and they're really interested?
So these are discussions that we have every day as dermatologists that focus on aesthetics. Patients come in for a cosmetic consultation and they identify a concern. In some cases, it's lentigines and brown spots in areas of pigmentation. And in other cases, it may be severe etched lines and wrinkles. So I really try to get an understanding of what bothers them the most when they look in the mirror and what they're going to be happy with in terms of seeing improvement of first. And then secondly, I really just try to get an understanding of what kind of downtime they can do. So I like to show them different options, and I like to show them my results and my patients before and after pictures so that they can really get an understanding of not just what the before looks like and what the after looks like, but in many cases, the sequence of how they got there over the course of several days, or in the case of heavy resurfacing, several months.
Absolutely. And I have to give you credit, Dr. Cohen. You're so good at showing that progression with your photos. And I think that's so important for patients to see. And so if any of you watching our patients are interested in lasers, make sure you ask your physician, you know, do you have photos? Do you have before and afters? Do you have anything to show me? You know, what can I expect? Because I think that's really helpful. And photos really tell the story. Would you agree?
Completely. And I think that, you know, really you get a better understanding of what people can do. If somebody looks at photos and they look at non-ablative fractionals, such as a 1927 series of laser treatments, and they see the improvement that they're looking for, then I would stop right there, because you can do 3 treatments or maybe 4 treatments and have a few days where you're just a little pink and a little dry and give people great results. They don't necessarily have to miss any work. And the downtime is not something most people would really even question. I would just have them avoid any major social events.
Yes. And I always say, I try to give them a timeline. So similar to what you said. So, you know, if we did the laser on a Thursday, for example, you might want to take Friday off and then, you know, lay low for the weekend, no major social events, as you mentioned. And then Monday you'd be, you know, good to go. Maybe a little bit of, you know, rough skin around the frontal hairline, but otherwise good to go. And I think we're both talking about some of our non-ablative laser technologies. Would you agree there?
Yes.
Mhm.
So, and then if people are really, they're looking in the mirror and they point to me and they say, look at these etched lines and wrinkles. My daughter's getting married in 4 months and I really want to do something about it. I want to look better. Then that's a conversation for heavy resurfacing. And in my case, I like to do full field erbium resurfacing. And I think really we got to pick the right tool for the job. So for many people around the mouth and around the eyes, where they have significant etched lines and they have something upcoming, such as a major family member's wedding or bar mitzvah or whatever the case is, then that time frame is super important. I gave the example of 4 months purposely because, you know, it really takes a while for the whole recovery process to happen. And in the case of like usually 1 session, heavy full field erbium resurfacing, patients can be red and that subsides to pink for even 3 months. So some of this I learned from folks like Jay Burns and Jason Posner and Susie Kilmer over the years. And Jay Burns has a great saying that post-treatment redness is the highway to get to the destination. So I get people to understand that's part of the process. I show them my patients' pictures immediately when we finish treatment, and these patients have bleeding and pinpoint bleeding all over their mouth. They have coagulation around the eyes. I show them what things look like a day or two later because I see these patients very regularly.
Yeah.
And these patients get my cell phone. If they have questions, they can get in touch with me directly. And I like to see them until they've reepithelialized. And then even after that, we tend to see them about once a month for 3 months just to check in and see how they're doing. You know, when you mentioned this is kind of laser season, you know, we call this time of year mud season when people aren't skiing, but it's just before ski season. Same thing, you know, in the spring, it's just after ski season. And we have so much sun exposure here in Colorado, and people enjoy outdoor sports at altitude. So with 315 days of sunshine or more, we can't really necessarily pick a perfect season for somebody to do resurfacing. For some people, they get more sun exposure in the winter, skiing and boarding at high altitude. And for some people, they're hiking or playing tennis in the summer. So we really have to think about these things and think about really great, rigorous sun protection to avoid hyperpigmentation.
Yeah, absolutely. And great point about the laser seasons. I mean, we in upstate New York and in the East Coast, it's sort of termed that way, but I agreed in Colorado, you have sun every day. And so it's just sort of picking the right treatment for that patient's particular timeline. I think we started at a really high level going straight into ablative. And so just for some of our viewers, can you break down like, what does non-ablative lasering do? Like, what does that do to the skin? Just so we can sort of start from the basics.
Sure. So ablative basically means vaporization. So the tissue is vaporized. So we associate that with downtime procedures, and then non-ablative procedures are things that really don't have much downtime. So we can treat pigmentation with non-ablative treatments. You know, very often for isolated lentigines, I'll use a Q-switch laser, Q-switch 532, Q-switch 1064. For people who have redness, very often I'll use a pulse dye laser or pulse dye laser plus a long pulse Nd:YAG laser, especially if they have larger caliber vessels around the eyes. If somebody has both redness and pigmentation, you know, some of the broadband light devices like BBL Hero has been my go-to for the past couple years, and really seeing great amounts of improvement using a filter for pigment followed by a filter for redness, or if redness is predominant, then the filter for redness and then pigment. So there's other devices out there like the Icon Max G that can be really helpful, again, for redness and pigmentation. And then, you know, for people who really want to see improvement in sun damage and see global improvement, there's non-ablative type fractional treatments that, as we discussed before, is poking little holes into the skin with these columns. And these microscopic little columns really don't have downtime. There's no coagulation there. So somebody might look a little pink, slightly swollen, perhaps a little dry for a few days. So 1550 nanometer laser, 1540, and then the very versatile 1927 thulium lasers, and there's many different examples of that. Yeah. And thulium is really the laser procedure that I think is integral to many dermatology practices because it can help treat pigmentation, it can help make the skin look more luminous, and really feel smoother. Mm-hmm. And then we know now from some studies, there was a recent article that was published by my good friends at Mass General, Matt Avram, the lead author is Benson, but they looked at really people who've done sequential non-ablative fractional treatments, and they compared those patients to people who hadn't done sequential non-ablative fractional treatments, but they looked at the cohort of people who've had basal cell and squamous cell skin cancer in the past. And what they showed is that when people do these fractional non-ablative treatments, so again, very little, if any, downtime, people have a significant reduction in non-melanoma skin cancer on the order of about 50%. Yeah. So I think that article by Matt Avram really changed many of our practices. It's a retrospective study, meaning I went back and looked at chart reviews, and I think people at this point are doing prospective studies, but there have been prospective studies looking at the influence of a procedure versus following controls, One was done by Basil Hantash, looking at the fact that laser procedures can significantly decrease the risk of having non-melanoma skin cancer. So it's repairing and remodeling and restoring a youthful appearance of the skin, and in some cases on a genetic level as well.
Yeah. That's some very fascinating data. I also came across it and heard Dr. Abram present it. And I think that's sort of game-changing knowledge for us and for our patients as well. I just want to circle back to all of the amazing things you just told us. So we heard that lasers can treat redness, they can treat vessels, they can treat lentiginous, brown spots, they can treat fine lines, wrinkles. There's so many different sun damage, they can prevent reoccurrence of skin cancer. So there's so many amazing things that lasers can do. And just hearing you speak about all the different types and different options, I think is truly a testament to the expertise, the level of expertise that dermatologists with our training have. And so that's just an important point to drive home. The second piece, and my question for you is, can you talk a little bit to the audience about combining these treatments? So, we know they can treat all of these different things on the skin, but as you mentioned, there's not just one treatment, for one condition. So do you combine treatments for patients, and does that make it more efficient for their visits?
So I combine treatments on virtually every single patient having a laser procedure. So we designed our laser rooms when I was building out our current main office space to really think about the configuration of the power grid in the room, to understand that in many cases we had a laser that required 220 or two lasers that required 220 at the same time. We have an air evacuator, and then we have a chiller, an air compressed air cooler. So then in addition, oftentimes I'm using another laser or even a third laser. So we've put together, and I've put some safety protocols together for our office. One of my many unflattering nicknames that my wife started and some other started is Safety Joel. We have to think about, when we're changing different lasers, we have to be responsible for making sure our eye protection is right. So
Absolutely.
if I'm the captain of the ship in the room, I need to look around and make sure that the medical assistants, the nursing staff, if a patient has a family member in the room, the patient, and anybody who potentially may come into the room is protected. So we have a whole sign of, we double check the eye gear is consistent with the laser, and then somebody in the room is checking me to make sure that somebody's taking care of me, because it's happened where I've looked and taken care of everybody, and then I've realized that the flash goes off. Oftentimes it's a pulse dye laser or something, and I realize right away that I don't have the right eye protection on. So, and then we have a sign on the door, laser in use, and then typically there's an extra pair of glasses with that in a case, just in case somebody has to get in the room.
Yeah, so eye protection is so important, and one of those things that just cannot be overlooked. So I think, having that title as Safety Joel is absolutely necessary in whatever capacity, that doctor is practicing. But it's so important to have all your safety protocols in place. So just to circle back, we talked about combination treatments, how there's strategic placement of the lasers in the room. If you had to just tell us off the bat, what is your favorite, 1, 2, 3 combination? What's your most popular combination treatment?
I think that for me as a dermatologist, seeing patients of different ages and different types of issues, I think really some of the most gratifying treatments I've done are the treatment of scars.
Yes.
So for some cases, these people will come in and they have very significant acne scars, and within, a few treatment sessions, you can change the appearance and dramatically minimize the acne scars. And we can talk about the different lasers and different approaches to do that. Some people have traumatic scars from a car accident. There are domestic violence cases, and I take care of a number of people, and they come in for a cosmetic consult, and you can tell right away they're very emotional. And for me, I want to make those patients better very quickly, and I tend to jump into some of the ablative fractional lasers just so that they can see more difference more quickly for the right situation. And then, in terms of other types of traumatic scars as well, and then skin cancer scars. As somebody who's done a Mohs College fellowship, I've created a lot of scars over the years, and not all of them have looked perfect. And, you know, the ability to really use a laser or a combination of lasers to make a scar look better has been really, really helpful in my practice.
Yeah, absolutely. I completely agree. I mean, similarly, I work in a university setting, but we work closely with our Mohs docs and are treating a lot of scars, traumatic scars, cancer scars. And agreed, it's just so gratifying to be able to help these patients. And we have to treat, this is a whole nother topic, but, it's treating scars, but we have to treat based on what we see, right? Whether they're thick, they're atrophic, they've got some erythema or pink to them. There's just a whole host of devices, and it's a nice place for combination treatment. So yes, completely agree there. Just switching gears a little bit, we had a question come in, and thank you all for dropping your questions. Please continue to give us your questions. We'd love to answer any that you have that come up. The question was about, is it safe to treat darker skin tones, skin types 4 through 6? Do you treat darker skin tones? We've heard myths in the past that, absolutely not. Darker skin tones cannot be treated with laser. So can you debunk that for us?
So I treat darker skin tones every day with lasers, and I know you do as well, Mara.
Yeah.
And I think people have a lot of misperceptions about lasers. So there's different lasers, there's different wavelengths, there's different targets, and different lasers have different downtimes. And we use the example of thulium 1927 before. It's really the most versatile laser that's out there because you can treat so many different types of skin, and you can treat type 6 skin. Obviously, when you're treating darker skin, you may want to turn the settings down.
Yes.
In some 10 or 15%. You may do less passes, you may stack less pulses, but nevertheless, if a patient that was African American had significant acne scars, I would have no problem going ahead and using a non-ablative fractional laser as my first line therapy. I would do bipolar fractional radiofrequency as well. Not a laser, but oftentimes patients will associate it with a laser just because it's an energy-based device that looks like a laser and stands next to a laser, but we
Yes.
difference, it's not a laser. And then in some cases, I'll even go ahead and focally use a fractional erbium device as well,
Yeah.
just something like acne scars better in certain areas.
Yes, I do. Yeah, I wanted to throw it out there. I do treat a lot of darker skin tones, so yes, absolutely. But it is something that I think a lot of people think cannot be done. And so that's really, again, why you want to go to an expert in the field to make sure that, the right settings are chosen, the right devices are being used. And often we see patients who've been treated, for example, for, hair removal with the wrong laser, the wrong setting, and have horrible scarring. And so just take caution when it comes to things like that. If your skin tone is a little bit darker, even if you're tanned, to be very careful about who you see to have that first laser treatment. So we have a question about how you would treat hypertrophic and keloidal acne scars. We're back to our scarring topic.
Sure. I see our close friend, Jeremy
Yeah.
Green. This.
Hi, Jeremy.
Jeremy, who probably asked that very tough question. So, hypertrophic scars, which basically are thickened scars. So, people come in all the time and they in an intake form, they indicate if they've ever had a history of scar abnormalities or keloids. But when you really pare this down, and you're looking at scars that become thick, but they're not extending or mushrooming beyond the confines of the area, I think that there are ways that you can make things significantly better. A lot of times for a hypertrophic scar, let's say it's a skin cancer excision and it's over an area that has a lot of movement and tension, let's say, the shoulder or something like that. So if somebody has a thickened scar to that area, I'll usually start with intralesional steroid and see how things really help in that respect. I don't like to do that closer than about 5 or 6 weeks apart. Sometimes, and depending on the patient's specifics, I'll add some intralesional 5-FU, 5-fluorouracil. And then for scars that are thick and red, very often I'll incorporate a pulse dye laser. And these tend to be low energy and very short pulse durations. when I'm treating these types of scars. So they typically will have some purpura or bruising for a little while. And then oftentimes I'll actually use laser-assisted drug delivery. So I'll use a non-ablative fractional device or an ablative fractional device, and really take the Kenalog, the 10 milligram per cc Kenalog, and sort of drizzle it over the area. And this has been really well established at this point. So Jill Weibel with Adam Wolkin had published on this. Christine Direks has done a tremendous amount over the years in laser-assisted drug delivery, and always gives one of the most exciting talks at ASDS and ASLMS about her innovations in her lab in Copenhagen, as well as at MGH, Harvard's program.
Yes, I've also similarly adopted the technique of laser-assisted drug, especially with removing keloids, and just found incredible results, and the longevity is there. So at this point, patients are coming back 3 to 5 years later and their keloids are still gone, which is quite impressive. You know, it's not what we're used to hearing, where the recurrence rate is just so high. So I really think this, you know, we thank Dr. Weibel and our team for their wonderful research and sort of getting everything out there so that the rest of us can use these techniques. So thank you for breaking that down. I saw another question here come up. It's why does redness appear for a long time even after regeneration is over following CO2 laser resurfacing? So why do we get that sustained erythema?
You know, post-procedure redness after a heavy ablative means vaporization. So the skin is actually being vaporized and there's a wound healing response. So whether you're using full field CO2 or full field erbium, patients tend to have redness, sometimes for several weeks or even a few months. It's not uncommon for some of my heavy full field erbium resurfacing patients to have post-treatment redness for 3 months. So first, again, I like to show them that that is part of the process. I like to give them Jay Burns' quote that that's the highway to the destination to getting the results, and really show them my results and show what things look like at baseline versus 1 month, 2 months, 3 months, and then usually by about 4 months that post-treatment redness is gone. So what's happening there? You know, there's really neovascularization, yes, and there's a blush that happens as new blood vessels try to heal that area. And we see that very commonly in surgery as well, if we're doing skin cancer surgery on the face especially. So it seems that patients who are fair complected with a tendency to erythematous telangiectatic rosacea, what we used to call type 1 rosacea, have more of that post-treatment redness. So we expect it. That reactive hyperemia is something that we know it's going to be there. I don't usually intervene and treat that very quickly, but okay, Mitch Goldman, who I love and respect a great deal, and if you look at who's published the most in the Journal of Dermatologic Surgery, Mitch Goldman is #1 in the current ranking. I think I was 12. Mitch Goldman published an article specifically looking at using topical steroids after resurfacing, found that really it can decrease the redness, but it doesn't interfere with that neocollagen and new collagen formation. It's just not something I jump into right away. If patients still have it at 3 months and some social events coming up, sometimes I'll go in there with a pulse dye laser. Okay. I'll actually use a non-ablative fractional just for a little bit of coagulation. Very often I will use a topical product that actually can help decrease redness, and there are some, and then there are some prescription products that I don't use for long-term, but some of the products like Mervaso and Rofade can be helpful at post-treatment redness as well.
So just talking about post-treatment, so what are your post-treatment instructions, let's say for, you know, fully ablative procedure, and how important is patient compliance in that process to ensure proper healing? What are your instructions?
So, you know, again, I like to do really heavy resurfacing, and I see people from different places that come in town in some cases, you know, they don't realize that how significant this procedure is going to be, even if we've done a consult or met over the phone and looked at this sequence. So I make sure everybody before I start the process is on the page of, here's what things look like when we finish the treatment, and this is what things look like over the course of the next week and a half or so. And I want you to be here in town. We're going to check in on you. I want you to come in. We'll clean you up. But I do give patients a few things. So first of all, I give them a really, really gentle cleanser. And it's a stock size gentle cleanser. And then secondly, I give them white petrolatum and just plain white petrolatum. And then third is I give them hypochlorous acid. And
Yes.
I want them to wash their face 2 or 3 times each third of the day. I want them to use the white petrolatum and not something else, because I've seen patients with contact dermatitis issues. And then I would like them to also supplement their cleaning with hypochlorous acid. So those 3 things are really key. And then once they've re-epithelialized, I want them to use a sunscreen that has a tint, because we know that tinted sunscreens have high energy visible light protection, specifically more iron oxide.
Yes.
The overwhelming majority of blue light exposure comes from the atmosphere. During COVID, there were a lot of articles and lay papers and things like that talking about the blue light exposure from screens. It turns out that that's very little compared to what we are exposed to outside.
What's your go-to tinted moisturizer? Do you have a few favorites?
So for my go-to moisturizer, once they've re-epithelialized, I like the Sente Dermal Repair Ultra Nourish because the HSA in there, heparin sulfate analog, has been found to, first of all, decrease redness. I just published an article with some folks, including Rich Gallo, that looked at pulse dye laser decreasing redness versus Dermal Repair Ultra Nourish plus pulse dye laser. And the Dermal Repair Ultra Nourish plus PDL performed better and noticeably better. And plus, it actually helps restore the barrier of the skin. And there's even studies about neocollagenesis and neoelastogenesis. So I think those actually aspects are helpful. And there's some studies even indicating that that can help decrease post-inflammatory hyperpigmentation. If it's somebody I'm really concerned about post-inflammatory hyperpigmentation, or they're starting to develop some of that, I want to make sure that they're using a vitamin C product that has THD ascorbate. We know that THD ascorbate is, number 1, more stable, and number 2, more effective. It penetrates the skin, and the lipophilicity of these products actually allows it to penetrate not only the epidermis, but into the deep dermis compared to L-ascorbic acid. So I'll have them use something like the Revision C Plus correcting serum twice a day, and then something like the Sente cysteamine for about 15 minutes a day. And then for some patients, I'll jump into a hydroquinone for a short period of time, but this can be irritating to some patients as well. So I really try to figure out a good formulation for them and a good regimen for them to do. But gosh, I would really like them to avoid that post-inflammatory hyperpigmentation. I resurfaced somebody, gosh, it was about 2 years ago now. She was an avid golfer. She promised me she would not be out golfing. It was like March, and she was taking it easy. She wouldn't even enjoy spring skiing, and she was really going to be careful. She was type 3 skin, and she admitted to somebody who was great about sunscreen, and she came back in about 6 weeks later. Her lines and wrinkles looked great, but she had some post-inflammatory hyperpigmentation, and I threw the whole kitchen sink of what we talked about at her. But the thing that was most important was just embracing the tinted sunscreen that had iron oxide. So back to your question about
Yes.
what's with iron oxide. You know, I think Elta's new rose-colored Luminous, so we did some of the testing on it originally, and my family had used it. It's a great it's a great tone for people who may be fair complected. And then Sente has an even tone sunscreen. The lighter formulation, the mild formulation, is good. And then for people who have, you know, a little bit darker type 3 or type 4 plus skin, I think there's nothing better than the Revision True Physical sunscreen.
Yes.
True has high concentration zinc and titanium. It has iron oxide. So it protects against blue light. It's got many different peptides. It has THD ascorbate, and it actually, interestingly, has DNA repair through a plankton extract. So those are really go-to sunscreens.
Yeah, thank you for those. I'm gonna write them down, taking mental notes. I also have to throw in the Hydro Tint by Elastin, which I love post procedure as well. It has great hydration and nice coverage for most skin tones. But just kind of summarizing what you said, it sounds like there's really no like one plan for everybody's recovery. Every plan you described is very customized to exactly what they're experiencing. So whether it's more erythema, prolonged erythema, if they're starting to get some hyperpigmentation, you'll add some brightening agents, some hydroquinone. So I think, the point is that every patient's post-care treatment looks a little bit different at the end based on how they're doing. And something else that you said that is so important is just the follow-up, right? So you said that patients will come in and you'll see them and clean them up and help them with the post-procedure care. In my practice, we see them every day for about a week post-ablative procedure, and help with the cleanup and just make sure that everything's healing okay. Is that about what you do as well? And then you'll see them at, 1 month, 2 months. What does that post timeline look like?
For my heavy resurfacing patients, I will see them about every day or every other day.
Yeah.
So they've re-epithelialized, which is oftentimes about a week and a half. In some cases, it's 2 weeks. But I want to detect change. I want to see, if there's something going on. And, we've both done enough of this over the years that these little subtle type things where somebody might actually say, I was doing better yesterday, but now I'm feeling some stinging and burning. And you're like, why don't you come in and we'll take a look what's going on? And sometimes you identify little pustules, an early onset infection. And, if I'm ever suspecting infection, I will take a culture because things have actually not responded to something like cephalexin. And you kind of scratch your head and say, I wonder what this could be. So if I'm suspicious of infection, I'm putting somebody on antibiotics, I will take a culture. And it's really interesting what grows out. We had an oral cavity bacteria from canines that grew out, and somebody was letting her dog inadvertently or purposely, I don't know, lick her face after she had a
Yeah.
procedure. There's an infection. There are situations where I tell everybody, avoid a dusty, dirty environment, just stay home in a clean environment. And now I ask everybody, do you have horses? Do you go to a stable? Do you have stables at home? Because many people ride here. My younger daughter rides as well. And for many patients, they want to go visit their horse every day. They want to feed their horse. And we've seen some really interesting things grow in cultures. So I want them to stay away from that. They need to make arrangements for somebody to care for their animals and stay in a really clean environment. I've also seen a couple interesting, weird contact dermatitis. So, I think Aquaphor is amazing. We use a lot of Aquaphor in our practice. I don't personally use it after resurfacing. I've seen a lanolin oil allergy, softolol allergy, and then just recently I had an ASDS preceptor in the office a few weeks ago, and actually I had a patient that was sensitive to hypochlorous acid, and we're going to bring her back and do a patch test. But we couldn't figure out what was going on, and we narrowed it down. I'm just like, stop everything, just use things one by one, and I want you to tell me. And I kept her in the office for a while. I'm like, tell me what burns and stings. And it was definitely the hypochlorous acid, even at a point where she was choosing that. So that actually was a very interesting case.
Wow, I've not seen or heard of that yet with irritation to hypochlorous acid. I know we're using it. We're all using it more. So thank you for sharing that. That's interesting and definitely something to look out
My
for.
Raul Nanda from McGill is writing that up right now, and he was
Okay, awesome. Well, we'll look out for it. Just a few more things. I know we're being respectful of everybody's time here. For pre-treatment, just for some patients or some viewers who don't know much about laser, just going back to sort of the basics, do you numb for most of your lasers? What does that look like? Is it a topical? How long are they waiting, or are you injecting? Can you kind of walk us through that part?
a great question. So first, again, I do a lot of heavy resurfacing, and there's a lot of people out there that do resurfacing and ablative fractional resurfacing. Many people do it lighter, but in the case of people who are seeking out treatment for severe etched lines and wrinkles around the mouth and around the eyes, I do numb those patients. So, first of all, I give all these patients blocks. So infraorbital block, mental block. I go in the auricular temporal area and greater auricular area, supratrochlear, supraorbital area, and I will do blocks. I do have them use topical anesthetic to make the blocks a little bit more comfortable, but over the past, since about February, I've been using a device called Target Cool, which is these little CO2 cartridges, and that has been a significant change for our practice. I literally resurfaced a national sportscaster last week, and I said, can I videotape you saying this? And he's like, no. And he said like all the right words. He's like, because I did it on one side, just a plain block and infraorbital. I did it with the Target Cool on the other, and he used the words game changer. I could hardly feel that. I'm like, dude, let me just, you know. He's like, no. So we're buddies. So maybe one day he'll let me do it.
What was that called again? A CO2?
Target Cool. So it's
Target Cool.
basically these CO2 cartridges that you're expressing the cold air right on the skin, and right when the cold air is going in there, I put a needle in there, and I'm really making so that they don't feel the needle stick and they don't feel the distension on the skin.
Yeah.
So
yeah. Go ahead.
One of my favorite things to teach, you know, the residents and the fellows that come through pretty regularly in the office are like my Cohen's commandments, the 4 things that I think are essential to do for really trying to achieve less painful anesthesia. So, and I would add Target Cool as number 5, but number 1, if you can go through a hair follicle, that's great. Number 2, always go deep first. If you go deep, then you don't feel the distension on the skin, and then you go more shallow. And then the third thing is never put a needle into an area that you don't think is actually pretty numb from, you know, seeing that little white epi-blank. So I just want to clarify, for my nerve blocks, I use lidocaine with epinephrine. For my ring blocks and my sulcus block around the mouth, I use plain lidocaine, no epinephrine, because pinpoint bleeding is my most important target. And I think that's how many of us are better able to use full field erbium resurfacing rather than CO2 full field resurfacing. I think there are a few people out there in the world, like Susie Kilmer and Vic Ross, that can really, really identify the endpoint with full field CO2 and see that tissue contraction, maybe wearing loops. I don't think I'm that talented. I'm just a country boy from Denver. I would rather just take something that's easy to pick up. And from our experience in both of our fellowships, learning how to do dermabrasion, you understand what pinpoint bleeding looks like. And pinpoint bleeding for the area around the mouth or for actinic cheilitis resurfacing is easy to recognize, and you need to recognize it, but don't have epinephrine in your block because it will be a delayed reaction and you won't be able to acutely recognize that.
That's such a great point. This is great information. I hope everybody's taking notes here. Those are the little intricacies, though, you know, like those are the things that matter the most, you know, the endpoints and why you use Lido with epi in some places and not others. So thank you so much for sharing your knowledge with us. Just as we wrap up here, I'd love to hear a story of maybe, you know, just like a memorable patient, just not your new sportscaster, but just somebody who you've treated and what was their, you know, outcome and how did that make you feel? And I'll just start with a little anecdote. I think for me, some of the most rewarding patients that I treat are, I think we said this already, but are scarring patients. So especially the acne scarring patients. I had a woman come in her mid 40s, you know, horrible acne scarring, had been living with it her whole life. Didn't know that there was any treatment available until, you know, somebody recommended that she see me. We did a series of treatments. We mixed it up. We did non-ablative, we did ablative fractionated, and we really got her, you know, nice and clear as best we could. And, you know, that was a patient who just came in, you know, pouring out gratitude in tears. And something like that early on in your career just really solidifies, you know, why you do what you do. It's not all about, looking a certain way or keeping up with the Joneses. It's really about changing lives and building people's confidence and their self-esteem and giving them options, I think. So that, is just something that's special to me and kind of what keeps me going. So just love to hear your perspective on that as well.
It's funny. My wife is a pediatrician and she did a fellowship in adolescent medicine. So, we talk about these things all the time. And, we used to say, what's the most common thank you note procedure? And for me, it's really, it's making scars look better, whether it's acne scars, traumatic scars, skin cancer scars. Interestingly, also one of the most common thank you note procedures is treatment of hyperhidrosis, where
Oh,
some
yes.
such great lengths to buy free
Yeah.
shirt, and they change in the bathroom every day and nobody even knows they have this condition, and they walk in and they got the blow dryers going on it. So, as dermatologists that specialize in, aesthetics, it's really interesting, patients send notes to, and these handwritten thank you notes mean so much to me. Once on my Instagram over the course of a week, I put a few of those out there because I keep these things. In some cases, I keep them on the wall, I mean, if somebody was to bring me, a 6-pack of some amazing microbrew, great, or a bottle of wine, some other gift, that's great. But these thank you notes really mean a lot. And I think if people are out there and they're thinking, gosh, should I thank my doctor or should I do something for him? Just write a thank you note for, your doc, and just, it means so much because in some cases we don't even realize, what these treatments have done. But for, somebody who, I have a patient who had a large domestic violence scar on her forehead, and she came in for neuromodulators, and I was able to make that scar look better over the course of a couple treatments. I did some subcision, I did some ablative fractional. She was able to wear a baseball cap to cover up those treatments while they were happening. And then she looked like a totally different person, especially during, some of the, therapy that she was going through. It wasn't a really, you can't look at it and be reminded every morning of the trauma that somebody went through. I had a kiddo who was sledding at grandfather's ranch, and somehow, there was cattle there, and a barbed wire fence was down, and he slid into this barbed wire area, and we were able to make the scar look significantly better. So, all those patients are really touching stories. And so my son, who's now 15, but when he was about 4, and he's tough personality. He's, engages you and questions you why you do things. He had this spider angioma from bumping into a table on his cheek. And I have to say, this is one of the toughest patients I ever had, was my kid. So he bumped into this table, and it was during like the swine flu years, where literally like every person in town thought that he had a little lipstick on his cheek, and they would lick their thumb and they would try to wipe his lipstick off. And my wife and I are looking at each other. And then I begged him, I'm like, just give me one shot with the pulse dye laser. I'm just going to make it better. So we took the Visia camera with his cute little pudgy face. We took the picture, and he said, Dad, I'll give you one shot. And I'm like, all right, what if I just hold the laser in the same spot? I don't move it, but I get 2 shots. And I did. I put a really short pulse duration, and I was like at 6 joules, 1.5 milliseconds, using the 10 millimeter spot, so it would make sure to get any feeder vessel and go deeper. And sure enough, I made it go away. I gave him a bruise for 5 or 6 days. And we still laugh about that because I was worried he was going to get sick all year from everybody putting spit on his face.
Wow, that's incredible. It's always your own that are the hardest to treat, right? Just convincing them to go through the treatment. That was amazing. Thank you for sharing. Okay, in the last few minutes, I want to know your top 3 skincare ingredients, totally off topic, but what are your top 3 must-haves when patients say, like, what do I need to use for skincare? What are the top 3 things?
Well, first, I would answer probably for, everything, a retinoid, a
Okay.
great sunscreen, and then, probably some antioxidant. I think most derms would answer the same.
Yeah.
for quenching free radicals, for the environmental pollution. I don't think people realize, but like 40% of American cities meet the definition of the World Health Organization of having significant pollution, and Denver included. So, I went to medical school in New York, and I remember running around. I was at Mount Sinai. I remember running around the reservoir with friends sometimes. We'd come back from the reservoir, and I'd be running up Fifth Avenue, and I'd literally be running behind a bus,
Oh,
thinking to myself, this can't be very good for my lungs. But little did I know, it's not very good for your skin either. And the
absolutely.
pollutants out there are incredible. So there's a lot of people here who are, they run these river rafting programs, or they have a whole series of like camping adventures over the summer, and they're in front of a fire all summer. And, that's not good for people really either,
Right.
and type of exposure. So the dust and the dirt and the grime and the pollution and all these other things. So I think an antioxidant, makes sense as well.
I'm right there with you. It's antioxidant, sunscreen, and retinoid or retinol, whichever, you can tolerate initially. So, Dr. Cohen, this has been so much fun. Thank you so much for everyone who joined and have stayed on. That's huge for us, and we just are so grateful to Dr. Cohen for letting us pick his brain and sharing all of your incredible knowledge. This again was the ASDS True Skin Experts live session, where we interview experts in the field of dermatology to really get that true information, accurate information out there. So thank you for listening, and join us next month for another session. And it will be posted. I see a question there. Yes, it's being recorded and it'll be posted. So if you missed anything at the beginning, you'll be able to watch it again. Thank you all for being with us. Have a good night.
Thank you so much, Mara.
Of course.